you for the kind introduction, and it's a great honor for me to be with you today. So, cancer is thought to be a genomic disease, since a normal cell becomes a cancer cell via a succession of DNA alterations. So Travis McCready mentioned this morning the technology revolution, where we can now sequence the whole sequence of a single cell within weeks or even days, and for reasonable cost. So that technology clearly applies for the field of oncology that is thought to be a genomic disease. So this has led to a new kind of clinical trials that assess the value of using high-throughput technologies to guide treatment. So this is the outline of my talk, and I will start with some basics, because I'm not sure everyone here is familiar with cancer. So for those who are familiar with cancer, so I apologize, but I think it's very important to go back to the basis. So there are two distinct situations in oncology. So the first situation is when patients have only a primary tumor inside. And the second situation is very different, is when patients have a distant metastasis. So why I am saying that? Because for patients with only a primary tumor, the key players here are surgeons and radiation oncologists. Even medical oncologists like me do not play like a huge role. So we can give drugs, but for a limited time, and it doesn't add that much to surgery and radiation therapy. And here, genomics has nothing to do. Now in the metastatic setting, so things are different, because there is little space for surgery and radiation therapy. And now we only have drugs that can go potentially everywhere in the body. In that case, treatment is given for life, and only 5% of patients will be cured, so meaning that all other patients will die from their cancer, except a few exceptions like germinal tumors or lymphoma, etc. So what kind of drugs we have? So we have cytotoxic agents, so chemotherapy, that are not very specific to cancer cells, so they target the cell division machinery, so they destroy cancer cells, but also all dividing cells, so also healthy cells. And since the late 90s, we have molecularly targeted agents that modulate specific pathways in the tumor cells and are supposed to work only in the presence of the target. So the target can be like a ligand or receptor or an intracytoplasmic pathway or intranuclear pathway. And some of them have been very successful. So I give you here the example of patients with breast cancer. 15% of patients with breast cancer have an amplification of a gene which is called HER2. And we have drugs targeting HER2, such as trastuzumab or lapatinib. For patients with a primary breast cancer, giving trastuzumab for a year allows to decrease by 50% the risk of recurrence, which is huge. In the metastatic setting, giving trastuzumab to these patients allowed to increase the overall median survival from around 2 years to more than 6 years. And I even have patients on trastuzumab for now 15 years, although they have a metastatic disease. So 10 years back, these patients would have died from their cancer. So let's move to the concept of precision medicine. So this slide illustrates the way we treat cancer today, so namely per tumor type and organ location. So depending on the histology and the location of the cancer, we choose chemotherapeutic agents or targeted therapies, even if in some cases we need to check whether the target is present or not. But this is the way we treat cancer, at least in the metastatic setting. We now know from the TCGA data that most of druggable molecular alteration exist across various tumor types, including mutations or gene copy number alterations. So as an example, we now know that 15% of patients with gastric cancer already have an amplification of that specific HER2 gene. And here again, giving trastuzumab to these patients improves their outcome. Another example is that patient with lung cancer, but with a mutation of HER2, and that patient responded to a HER2 inhibitor. And really the question is whether in the future we should treat patients according to the molecular profile of the tumor, independent of tumor location and histology. So this is a histology agnostic approach, which is not the approach we use in the clinic today. So when using such an approach, what is key is the treatment algorithm that is being used. So namely, from the results we get from the molecular profile to the treatment we give to the patient. And the treatment algorithm has several features. The first one is what technology was used to identify molecular alterations. Was that ion torrent? Was that whatever you want, Affymetrix, etc. Second, what are the thresholds used to claim that a molecular alteration is a driver? And I will come back to that when I present you the Shiva trial. What is the molecular alteration drugs matching? So in case of that molecular alteration, I would give that drug. So, and this needs to be specified. And then, if there are many or several molecular alterations, what is the prioritization? So the question now is what clinical evidence we have toward this concept of precision medicine. Because at the end of the day, what interests patients is whether that approach of performing a molecular profile of the tumor of cancer patient does improve their outcome as compared to what we do in the clinic on the right. In other words, it's very important to assess the clinical utility of the concept of precision medicine. And this is what we have tried with the Shiva trial. So that trial was run by the Institut Curie, in Institut Curie and 8 other French cancer centers, including Lyon, but also Marseille. This is for the ambassador. In that clinical trial, so all patients with refractory cancer, so any type of cancer that was refractory to standard of care, had to undergo a biopsy of a metastatic site. Some molecular analyses were performed in this patient using targeted sequencing, CGH for gene copy number alterations, but also immunohistochemistry for hormone receptor status or to validate or not any amplification or deletion. And all data were centralized in the bioinformatics department of the Institut Curie. We used to meet on a weekly basis, so with the platforms managers, the bioinformaticians, the pathologists, the biologists, and the medical oncologist to discuss the results of all patients. And if a molecular alteration was identified and the drug available, then the patient would be randomized between the matched targeted therapy, so using targeted drugs that are already on the market but outside their indications, versus what we do in the clinic. So you would ask me, but after failure of standard of care, what can you do? So what we do in France, we still give chemotherapy, so non-standard chemotherapy, but we give something, because it's very hard for us not to give anything to these patients when they are still in good shape. And these patients were allowed to cross over at disease progression, so meaning that patients randomized in the conventional arm could cross over to the targeted therapy arm at disease progression, so that all patients could receive the targeted therapy. So this was a part of the treatment algorithm. So here you have the targets, you have the molecular alterations we were looking at, and you have here the targeted treatments we were using. So you can see that we were using only single-agent targeted therapies. And you can see as well that the treatment algorithm was unidimensional. I mean with unidimensional that for one alteration we had one drug. So we didn't take into account several molecular alterations to decide treatment. Why? Because we had no data for this. And we did stratify the trial on the 3 main pathways, so the hormone receptor pathway, the PI3K/KT-mTOR pathway, and the MAP kinase pathway, so that we could do some subgroup analysis at the end of the trial. So part of the treatment algorithm are the thresholds. And here we decided to set up some thresholds to claim that a mutation is really a driver mutation. So for variants of interest, we were looking at validated hotspot mutations, and you can see here the thresholds in terms of frequency of the mutation or coverage that we used to claim that the mutation was a driver mutation. But this was our decision. You might have decided that 4% is not the right threshold. Maybe you would have decided 8% is the right threshold. Or maybe for the coverage, you might have said, oh, 30x is not enough. Maybe 100x would be enough. So here I raise the question of the treatment algorithm, and the thresholds are part of the treatment algorithm, because at the end of the day, the Shiva trial did not evaluate the efficacy of a specific drug in a specific indication, but only the efficiency of the treatment algorithm. So when using the treatment algorithm, do we improve patients' outcome or not? For amplification, this was the same, and I will not go into the detail, but we had to set up threshold to claim that some gene copy number alterations are really amplification or not. But here again, you might have decided that 6 for a diploid tumor, 6 copies is not enough, and maybe you would have used like 10 or maybe 4. That I don't know. This was part of the treatment algorithm again. And we had also some errors in case of multiple molecular alterations. So the trial was run between September 2012 and July 2014, and I have to say that accrual went twice faster than expected. So you can see here that the expectations from patients, but also from physicians, are very high. So had some patient coming to the clinic and thinking they would be cured with precision medicine. So saying, you will get the data from sequencing, and probably you will find the drug that will cure me. But this is far from reality. So in terms of feasibility, so we were able to have less than 4 weeks elapsed between the tumor biopsy and the molecular biology board. So meaning we had to learn to work with teams of the research center and not from the hospital. These teams were the platforms, sequencing platforms and CGH platform. So we are used to work with them for research projects where we have like 6 months to produce results. Here we have patients with a life expectancy of 4 to 6 months. So we needed to get the results very quickly. So DNA was extracted on the next week, and then a genomic analysis performed, and everything centralized into the bioinformatics department that had like a few days to establish a report for physicians. So, and you know that a report that a physician can understand has to be simple. And then we would meet on the next week to discuss the results. So more than 740 patients were included. Most of patients underwent the tumor biopsy of a metastatic site that would reflect what we would treat. 70% of patients had successful genomic analysis. Some of that, so 30% of patients had not, because the tumor cellularity was too low. But this is real life. So by taking a biopsy, so sometimes a radiologist cannot get like tumor tissue or too few tumor cells. So then 40% of all patients were eligible for randomization, so had a druggable molecular alteration according to our pre-specified treatment algorithm. And only 26% of patients were actually randomized. So why were 100 patients not randomized? Because their condition did deteriorate, and they were no longer a candidate for randomization. In terms of tumor types, so we had a lot of different tumor types, including breast cancer, ovarian cancer, lung cancer, all types of cancer. In fact, we were looking for heterogeneity. So we didn't want to have like 80% of patients with the same tumor type. So we had set up a bar at 20% for one maximum for one tumor type. So this is the result of the trial. So the primary endpoint was progression-free survival, and this is real life, actually. So you have here the progression-free survival, and you can see that there is no difference between the two curves. So your question might be now, is this the end of the story? No, I don't think so. I don't think so. First, because of the subgroup analysis, where we could see some difference in the patients with an alteration on the MAP kinase pathway first. And second, we'll present at the ASCO this year the results of the crossover data, where patients are taken as their own controls, patients who were treated with targeted therapy, but also with chemotherapy, and looking at the PFS ratio. And this data I cannot disclose today, but are very impressive, and we think we should continue in that way. So we think that the Shiva trial was not able to demonstrate the concept that precision medicine, according to the treatment algorithm we used, can improve patients' outcome, but we think there are enough data to push you in that direction. And the perspectives are, of course, Shiva-02. So Shiva-02 is a new clinical trial that will start in 2016 in France again, with a refined treatment algorithm. So as I mentioned, we used a unidimensional treatment algorithm. We will use a bidimensional treatment algorithm, including a resistance biomarker to targeted therapies. We are not able to use like a multi-dimensional treatment algorithm, because for this we need a lot of patients and retrospective analysis and using systems biology. So this is something we plan to do with the data of Shiva-01 with people involved in other clinical trials in France or in other centers around the world. So we are not able today to have multi-dimensional treatment algorithms. We'll focus on the MAP kinase pathway, obviously, where we had the best results. We'll use new drugs, because between 2011 and now, new drugs have come to the market. We'll use a new design, so we'll use not like a randomization between two different groups of patients, but every patient will be his or her own control, actually, and we'll compare the efficacy of matched targeted therapy as compared to the standard chemotherapy. And this will be the primary endpoint of the Shiva-02 trial. The goal also is to use circulating tumor DNA. So we are able in the Shiva-01 trial to demonstrate that we could find exactly the same mutations, not amplification, but on circulating tumor DNA as on tumor biopsy, and this was published last year. So what we want to do here is to assess mutations, but also amplifications, and we are developing a panel for this. And if conclusive, then use only ctDNA for genomic analysis in the Shiva-02 trial. And what we would like to do, and Emanuela will talk about that, we would like to introduce immunotherapy, because you might know that immunotherapy gave great results in some tumor types. And the issue with immunotherapy are the predictive biomarkers, but we are open here to open cohorts with immunotherapeutics based on some hypotheses on potential biomarkers. So with that, I would like to thank all the people at the Institut Curie involved in the Shiva-01 trial. So it's like 10 ETPs in total, so, but many more patients, around 100 people in the research center, but also in the hospital who were involved in the Shiva-01 trial. I thank you for your attention.